Great, thanks. Good afternoon. We're going to get started because we are 3 minutes over, and I do not want to. I know it's the last session of the day, and I want to make sure that we end on time, and maybe the bell will stop at some point here soon. So today's session, first of all, welcome. Thank you for coming. My name is Christina Bishop. I'm a senior HIV testing services advisor at USAID in Washington, D.C. at OHA. I recognize several faces here. And the bell is really getting old. It might go in the comment section. Yeah, I know. It's like there's a lot of angels right now with wings. Okay, so I'm gonna just try to ignore the bell. So today's session is on innovations in HIV testing, and we have, and we're going to be hearing from 3 of our partners on some of the practices that they're doing in HIV testing. So kind of the goal of it is to illustrate innovative strategies used by local partners in case finding and testing for HIV, and to share lessons. So hopefully we're going to have plenty of time for questions. Each session should be about 10 minutes. So today's presenters, we have Nelson Mahulu from Uganda Protestant Medical Bureau, and he will be presenting first. Rachel Manyake from Baylor, Malawi, and then Deuce Nyanyako, who is actually going to be online. So we will be hearing from him online when we connect, and so hopefully that goes smoothly. And then after that, everybody should have about 10 minutes, and then after that, we should, if everything goes as planned, have about 10 to 15 minutes, if not even a little bit more, for question and answer. I'm hoping that we can get some good discussion going. So I'm going to get started now that the bell has gone, and we are going to start. Nelson, welcome.
Thank you. Good evening. Thank you for the opportunity to present. My name is Nelson Mahulo. I work with Uganda Protestant Medical Bureau as the Senior HIV Prevention Advisor. So I'm going to share with you how we are leveraging faith community initiatives to optimize HIV services in Uganda. So briefly about Uganda Protestant Medical Bureau, we are a faith-based local organization with over 50 years working with faith structures to advance quality health services in Uganda. And we have also over 15 years supporting community and health facility HIV interventions in Uganda. So Uganda Protestant Medical Bureau is the prime implementing partner for the USAID local service delivery for HIV/AIDS activity. And this is a 5-year program operating in the 5 USAID supported regions of Uganda. So we have Eastern and East Central Uganda, Southwest, and then we have Acholi and Lango in the northern part of Uganda. We support over 187 health facilities, and these are located in 57 districts of Uganda. We also work with 25 civil society organizations. And our goal is in line with the PEPFAR goal, but also with the government of Uganda goal. So what I'm presenting today is under Objective 2 of our project. So just to give you a background of our innovation, in Uganda, about only 80.9% of people living with HIV know their status, and that is according to the Population HIV Impact Assessment data of 2020. So, and just like anywhere else in the world, we know that majority of the undiagnosed people are men. children and adolescents, but also key populations. However, for these innovations, we concentrated mainly on men. So a growing proportion of people who are living with HIV, especially those with unknown status, they actually feel healthy, and we have seen that they are not motivated to access health services. And because of this, they usually present to health facilities later in their disease when they have started seeing signs and symptoms. And this actually results in too poor treatment outcomes. Sometimes they come with advanced HIV disease, which has a very poor prognosis. So because of the poor health-seeking behaviors, like I've said, these people don't readily want to come to the health facility. So how do we reach them and test them for HIV? So we appreciate that in Uganda, faith communities are deeply established, and they actually people who rarely interact with health facilities. So Uganda Protestant Medical Bureau is leveraging this platform to optimize HIV testing. So what we did is we trained 951 faith leaders in the basic HIV curriculum. And this was a 5 days classroom training with some practical sessions. So basically what we covered was issues to do with how to pass across HIV messages of hope, addressing GBV, but also supporting HIV self-testing in the community. So the trained faith leaders were supported to establish 45 health windows. And health windows are basically community health posts that are established at places of worship. And these were established in 24 districts across the regions that we support. So at the health windows, faith leaders provided basic HIV AIDS education, supported mobilization of communities for HIV self-testing. They distributed HIV self-test kits in the communities. And what we started with was the oral test kits. And they were able to link individuals that had reactive results to health facilities. So to see that we continue building the capacity of the faith leaders, we conducted routine mentorships and support supervision, but we also established regional WhatsApp groups for coordination of different health windows within the same regions. So in the course of doing work, faith leaders were given data capture tools. These were customized HIV self-test kit distribution log, just to document who has received the self-test kits and be able to follow up on the results. And this information could later be transferred to health facility registers. So what you'll see here is one of faith leaders demonstrating how to use an oral HIV self-test kit. But also we had each health window developing a community facility referral map, just to see that in case there is a client who needs services that cannot be offered by the faith leaders, they can be referred to the appropriate service point. So the results, these were interventions that were piloted, and I'm giving you data for 5 months. So over 4,000 individuals, especially men, were reached with HIV messages of hope. Faith leaders were able to distribute 6,282 HIV self-test kits in the community, and 150 of these had reactive results. And according to the testing algorithm for Uganda, any client with a reactive result on HIV self-testing should go for confirmatory testing, since this is a screening test. So out of the 150 who had reactive results, 117 were confirmed HIV positive, and we were able to link 101 to care. Linkage here means these were initiated on ART, antiretroviral therapy. So we had a gap of about 16 clients not linked, and there was a challenge at the pilot of this intervention, where we realized that faith leaders were not very knowledgeable enough to do very good counseling and support linkage. However, this was addressed as we continued to pilot this intervention. So what we learn is church-led interventions can aid in reaching individuals who rarely interact with the healthcare system, and health windows can serve as advocacy and support platforms for HIV services. We also see that targeted distribution of HIV self-test kits by faith leaders is effective, and we're actually scaling this up. What we noted is that HIV self-test kits that were distributed by faith leaders were about 23% of the total kits that were distributed by the program through other channels, but we were able to contribute almost 50% of the HIV positive cases identified. Thank you so much, and I'll be welcome.
Okay, so our next speaker, we've got Rachel Minyaki.
Thank you and good evening. I'm Rachel. I am from Bella Foundation, Malawi, and I'm going to be asking this question to all of us, especially those of us who are involved in HIV testing. I think it's a question that most of us grapple with. Are we really over-testing? I don't know how many of us here have heard that word used, in our work. So a bit about, I have no conflicts to disclose, but let me speak a bit about our program before we go into the presentation. So Bila Malawi is implementing HIV service delivery program in Malawi, focusing in the southern part of the country, and we cover 6 districts, and basically we are focusing on achieving and sustaining epidemic control, like most of us are trying to do. And so we implement the whole cascade of HIV clinical services, right from testing, addressing through the 395s. So this presentation I'm sending here on behalf of my colleagues, some who are online and some who are here in this room. So we know that HIV testing allows people at risk of HIV to make decisions about their risky behavior, and they make a decision to access prevention services and also to access treatment services. But like I started with saying, there's been concern over the last couple of years that we have been conducting what we call, I choose to call, inappropriate testing, but the word that we hear is over-testing. But we chose to investigate that question through a quality control approach to check whether we are over-testing, and we did through because of the pressure that was coming from various circles in our work. We know that documentation to address, to know this, whether we are over-testing and quantifying whether the test that we do appropriate, has not been there. And so we conducted this exercise. That's a quality control exercise to assess the reasons that clients seek to have a HIV test. Why do they come to our facilities to request for a test? And this was done at the sites that Bella implements. We implement at 95 sites, and we did this in our districts that we support within Malawi, the southern part of Malawi, and the HIV testing in Malawi is actually provided, and I believe in most of our countries, is provided by lay cadres who are trained to provide HIV testing and counseling. There is a picture of one of our staff providing that test. So we conducted this CQI project in 5 high-volume health facilities in 5 districts. These were health facilities strewn from district hospitals to sub-district hospitals. And we administered a couple of questions to clients who presented at the OPD, at the HTS testing rooms, to ask them, why did you come to receive a test? So clients were queried, and we did this early this year, between February and March. Clients provided, various reasons for seeking a HIV test on the particular day they came to the facility. And we categorized these reasons into 2 categories, as you see up there, an inappropriate test and an appropriate test. And from the 710 who were interviewed or who agreed to speak to us, because it was an opt-in, it was based on their consent to speak, we found out that a couple of people had, various reasons why they came, but what we were looking for when we were doing this and categorizing as inappropriate test is people who already came and known to be HIV positive and were on ART, or people who had received a recent negative HIV test, and that's test within the past month, or did not have any exposure to risk to warrant them to get a test, or not enough time had lapsed, as recommended by the Malawi integrated testing guidelines to provide, a HIV test, or there was no HIV exposure at all. What we categorize as appropriate tests were for people who had previously tested HIV negative, but they had had a new incident of a HIV exposure. We know that, there are certain incidences, for instance, in the event of GBV, or, somebody was with someone who was probably, known to be HIV positive and they did not use protection. People seeking VCT for any reason. These are people who just presented for, for voluntary testing. People who came for confirmation of a positive self-test, and referral from HIV testing by a healthcare worker, particularly through ICT, that's index testing, or PITC, or any other, and of course medical indication for PITC. So our results from the 710 individuals that we talked to, 37% of those were men, and 63% of those were women. As we know, and I think as we heard today from a different presentation, women will always be more in our health facilities because they present more at ANC. The health-seeking behavior between the 2 gender, we know, is different. And out of the 710, the mean age of those who we talked to was 30 years, and they ranged between 13 years and 70 years. What we found out is that most clients actually came to the health facility on their own, which we call VCT, and that is about 66% of the 710. They just came because they wanted to have a test. And I was happy earlier today when Christine presented and talked about the changes to COP22 to just allow people who need to access testing to do that. And this collaborates that, because what we saw is that a lot of people just needed to know their status. That 2% were referred by a healthcare worker, and 10 of those who we interviewed had been referred by somebody else. So what we saw is that 10 of the people referred by HTS, or healthcare worker, were HIV positive on further screening. These 10 are different from the one I mentioned that were referred by somebody else. And so it means that they did not need to receive a test because they already were HIV positive from a previous test. Some of the top reasons for seeking HTS that we saw is exactly what I said. People just want to know if they're HIV positive. And that was 46% of the 46% rather of the reasons that we received, or followed by some people who had been a bit sick and they were not sure, so they needed to come and get a test, or they had been referred. Some were there because they had been told to come, probably by a healthcare worker or by a lay-card or staff. And the list goes on to the last, where it was a partner who was HIV positive, so they decided to come and get a test. But at the end of our CQI, what we found is that 98% of the people who presented at the clinic actually required a HIV test. So that the tests, 98% of the tests that were done were actually appropriate tests based on Malawi National Testing Guideline. 89% of the people had previously tested for HIV out of the 710 who we talked to. And men, like I said earlier, were more likely to be tested for the first time than women. This is because women get tests more frequently when they come to the ANC, unlike men who will only come to the health facility if they are too sick, or if they've been referred by a clinician or somebody else. So out of the 710 people we talked to, only 10 people presented with unnecessary reasons for testing, like I mentioned earlier. These are people who had already received a previous HIV positive result, and maybe they had doubts. They had doubted, from their first test, and they wanted to come and confirm again that indeed the test was correct. So that really explains that the 98% of the group that we tested was really appropriate. And that's our conclusion, that during our CQI period, we noticed that the larger proportion, actually just short of 2% of everybody who came, were tested appropriately and within the national guidelines for integrated testing that have been recently revised. And one of the things that we have to bear in mind is that if there's a reduction in HIV testing so that we stop what we call quote-unquote over-testing, this would lead to either a revision in the national guidelines to accommodate that, because the volume of the desired test, of the tests that we are conducting, are appropriate tests. And so if we're to reduce that volume, it means that we would be, in one way or another, denying tests to people who really need and who should be appropriately receiving a HIV test. I just want to acknowledge a few people, especially the people that we work with, the people that we support. Our program team, the Ministry of Health in Malawi, USAID, and all of us in this room. Thank you so much.
Okay, thank you. Next, we have our a virtual presenter. Just, are you on? Are you able to hear us?
Yes, good evening.
Oh, okay. Hello. Hi. Okay, so great. So I can advance your slides. So just say next slide when you're ready, and you can get started.
Thank you. So good evening, everyone. My name is Juice Mahal Malama.